So in picking up with the whole description of multisystem inflammatory syndrome in children, first descriptions began to come out of Italy, particularly as they were heavily involved, and subsequently, as the pandemic worsened in New York City, descriptions there, United Kingdom, France, the Netherlands, a number of countries around the world describing the same phenomena. And this process looked very similar to what we know as Kawasaki. And that is, again, a vasculitis, unknown cause in the sense of, is it precipitated by an infection, or is it that it has other, what we call host, meaning the child's own immune response. And so much research has been done around Kawasaki, and this syndrome began to have many clinical features with that. Some of the countries that looked back on their cases of Kawasaki that you see each year, and this is a described syndrome that's been present for 20 or more years, and they noted that there were much higher rates than they had seen before. So they began to realize that this perhaps was related to the infection with SARS-CoV-2. And so they then began clinical description and characterization, as well as treating the syndrome the same as we would treat Kawasaki. And so the case definition from that was developed. And for us, being able to learn and to be able to classify children that meet this all in the same way, these case definitions become very important. And so what families need to know is that these are temporally located in coordination with a COVID infection. That means that the child has had a COVID infection, the child has antibodies as having evidence of had a prior infection, because we know that people can have COVID infection with minimal to no symptoms, and that there's within a time frame of approximately 4 weeks this is presenting. So those factors allowed us to understand that link to COVID. So how does it look like our other inflammatory condition called Kawasaki? There's high fever. The fever persists for a period of time. There are rash. There are conjunctival injections, the red eyes. The children often have gastrointestinal problems, diarrhea, other symptoms. There's often swelling of the hands and feet. There is the sense that the children are ill. The additional components of this often revolve around the amount of low blood pressures, called hypotension, that the children may experience, and the rapid progression. Many of these children also had pneumonia, and whether that was directly related to the COVID infection or whether that was indeed part of this whole inflammatory syndrome. So just as we know that the adult disease process is driven a great deal by an inflammatory response, this process also is driven by the inflammatory response. And the treatments being both supporting them, both their electrolytes and supporting their blood pressures, monitoring their hearts carefully. Just like Kawasaki, this tends to affect the heart as well. So monitoring those and treating them with intravenous immune globulin have been the mainstays of therapy. Corticosteroids have also played a role, so that we are down-regulating the immune system and saying, we need you to turn off and stop all of this inflammation that you're producing. And so those have been the directions that the therapy has taken. We are participating, just as the rest of the children's hospitals around the country, in reporting these both to our local health departments as well as to the CDC via standard case definition. And through this, we're able to take a few cases in one center and combine them all together and learn more about the response to therapies, the keys to diagnosis, a better direction to give clinicians the ability to recognize this clearly, and address the treatments in a way that can speed the recovery for the children. For the most part, these children recover completely. We do follow them for quite a long period of time just to assure that all those inflammatory markers get back to normal, and that the children, following their echocardiograms and any other system that has been affected, like if they've had pulmonary disease following that, to be sure that there's a complete resolution over time. So at that point, Tammy, do we have any questions?
I don't see any in the chat. If anybody has a question, please put it in the chat so I can see it and read it to Dr. Lacroix, please. Somebody says they do, so I guess their fingers are working. Are there certain children, there are certain children who are more susceptible to the syndrome?
It's part of what we don't understand about this. So the science is still not clear. And when you look at the number of children that we know have subsequently been infected around the world, this is still a very infrequent complication to the infection. So we don't understand if there are children that are more susceptible to this. It seems to transcend a fairly large age group, so it doesn't appear that it affects young children more than school-age children versus adolescents. So there is a wider range. The case definition goes all the way to age 21. So again, that puts us into the young adult category. So there is not a clear distinction to help us predict who might have a problem with this. So I think the message for families is that if their child is sick and becoming more ill and has these symptoms of conjunctivitis, red lips, red tongue, rash, edema, meaning swelling of the hands or feet, are particularly weak, lethargic, fatigued, that they should seek medical evaluation of their child just to be sure that we're not progressing into this more systemic, multi-system inflammation.
This question is there any thought that a COVID vaccination may eliminate this disorder?
You know, I think that vaccine development is so early in the development phases, and certainly in the groups that they are doing the initial trials in. I don't think that there's any way for us to predict that at this point.
With school about to start, is it more likely that we will have more cases of this?
You know, I think that the fact that it's a fairly uncommon presentation in response to infection, I think that all of us, particularly in the infectious disease community, are monitoring very closely for that. So if we had more children with infection, we obviously want to monitor that if we are seeing more cases of this, that we are alerted to it very early. And I think that particularly the pediatric community is very well versed in the diagnosis of Kawasaki, because we have dealt with that condition, and just recognizing that this may look very much like that will help us with early recognition.
Is it only seen in children?
We have described it in children. There seems to be a different inflammatory response in the adult population, but I don't think that we can completely exclude that it does not involve adults. Adults, we know, do have some degree of vasculitis that is a component of their disease process. And so it could be that this is a spectrum. We've clearly set the case definition for 21. And in the instance that we're looking at saying who fits this classic definition, it would be within that childhood young adult category.
The question is about, do we have statistics on the number of children around the world or in the US who have gotten this? And do we know about like their hospitalization and ventilation and that kind of thing?
So the CDC is collecting all of these cases, and part of the reason to go to a case definition is that we can try to help standardize apples to apples and make sure that we are looking at that population, because we have this other category with Kawasaki that looks very, very similar. So in hopes of categorizing this group related to COVID infection, the reporting and the case definitions are what helped the CDC and DHEC determine that these truly meet the case definition and that they move forward in that data set for analysis. So to answer your question, those are being collected. Those are all reportable now. There's been a lot of work to notify all the children's healthcare providers around the country to report these. And internationally, not as robust of a central repository, but again, case definitions around those. And many of these are numbers from as few as 8 cases described up to 50 to 80 cases described. So again, when you place it in the context of the number of children that we believe have been infected, particularly in very severely affected communities like New York and Bergamo, Italy, where some of the first reports came from, then we can understand the rates at which this might be happening. But the true numbers, we are very dependent on reporting.
The question is, how worried should parents be about this?
So I think that we, as a group, as parents, need to help protect our children. We know that transmission from adults to children is the more common way, and parents being able to protect their children from acquiring COVID is the first line of defense. And those are the simple measures, like being sure that they're using avoidance of big crowds, social distancing, being able to mask, hand hygiene, which is very key for children to help protect them against a whole host of respiratory viruses. So I think that parents' first line of defense is to help protect their children. Subsequently, any viral infection has temporarily been associated with Kawasaki, which looks very much like this. So this particular post-viral response is one that I think parents have to be aware of. And certainly if children have had COVID infection and seemingly recovered and then become ill again, I think them having the index to say, wow, we probably need to get this checked out is the important key for families to follow.
Yeah. Dr. Lacroix, the question is, if a child is diagnosed, how long would they typically, if hospitalized at all, how long would the course of this in a child be?
Right, so most of the lengths of stay have been around 5 to 8 days. The treatments are given very early, literally within hours of diagnosis, and the support component in getting the children, if they're having vomiting and diarrhea, they need to be able to tolerate fluids and be able to come off of IV fluids and IV support. And so I think that has been the portion that has prolonged the hospitalizations the most.
Somebody is asking a question about whether the children who have been diagnosed, which I don't know that we're talking about specific children, but the question is really about pre-existing conditions and how it impacts something like this.
So in terms of making them necessarily more susceptible, we have not seen that association. Children, though, who have pre-existing conditions, say they were premature and have significant lung disease, if they acquired the infection and developed pneumonia, they potentially would have a much harder time with it. Children with congenital heart disease that already have compromised ability to maintain their blood pressure and heart function might have a harder time with this.
If it's not the MIS-C, how does the COVID virus impact children, and what symptoms should parents look for?
Right, that's a great question. So COVID-19, we know in children is a little bit different, probably only about between 50 and 60% of those children will go on to get fever, and about that same percentage will have cough. So it often will present like an upper respiratory infection that families may have seen their kids go through multiple times: runny nose, some sore throat, some headache, fatigue, and then fever and cough being the most predominant of the two pediatric symptoms, but all the others with the runny nose and congestion being close to those two predominant signs and symptoms.
I think you may have answered this, but are children more susceptible to COVID, and are they more likely to pass it along?
You know, it's been very interesting since the very start of the pandemic. When the initial reports were coming out of China, there were very, very few children that became infected and were subsequently hospitalized. And there is not yet well described why. The observation both around the world and certainly in this country as well, that children are less likely to become infected, and when they do become infected are less likely to require hospitalization, less likely to move into more severe infections. Then we know with all infectious diseases that there are certain people who are affected much more severely than others, and you know, our heart goes out to the family that lost their child in the Midlands to COVID. That there are always, with all viruses, whether that be influenza, RSV, adenovirus, or other viruses, they can take a severe course in children that were healthy to begin with.
Do you see or know of it, whether there'll be long-term immunity once a child has had this and recovers, or is reinfection possible? I know that's been a question on the adult level too.
It has been. And, you know, we are really 6 months into learning about this virus. And I think that question is still yet to be answered. And because there are different types of immunity that people carry, one of which is easy for us to measure in terms of the antibody response, but then there are other innate forms of immunity that are much more difficult to study and have to be studied in different ways. And so I think the answer to the question is that the science is not clear yet to give us that answer.
Did the medical community know of this before COVID, or do we feel like it's really directly related to COVID? And I guess you kind of talked about we're learning from other communities. What are we learning?
Right. So the multi-system inflammatory syndrome, which is I guess what we were referring to. So this syndrome looks very similar to another inflammatory syndrome called Kawasaki, which emerged and was described many years ago, first in Japan and then subsequently around the world. And so the post-infectious set up for the immune system to overreact to a infectious agent has been present for quite a while, and there's been a tremendous amount of research over a number of years trying to pinpoint a specific agent, and that really has not proven across multiple lines of scientific investigation to say that, oh, if you have this virus, you're then predisposed to go on and develop Kawasaki. So I think the idea that we have understood this inflammatory process before is definitely true. I think the difference with this is the degree of additional organ involvement that we see, and particularly the hypotension and a little different effect on the heart than we have seen with Kawasaki, which typically involves the coronary arteries. This particularly inflammatory response has also caused some decrease in cardiac function, and us being able to support the kids with IV infusions to support their blood pressure and their cardiac function has allowed the downregulation of the immune system with the immune globulin and steroids to have the effect, and we support them through getting the immune system to slow itself down.
So I think, Dr. Lacroix, this is kind of a second part to that. It's talking about lasting effects, what are the possible long-term effects even after recovery? Are people more susceptible for like respiratory or cardiac problems?
Right. And again, being 6 months into this process, it is unclear. We know from our experience with Kawasaki that we believe that those children recover and subsequently move forward without any long-lasting effects. With this, we know that a number of those children very early that were described are doing very, very well and having no clinical sequelae to having had the multi-system involvement.
I think somebody got on late and they just wanted you to do sort of your little comparison on how it's different from Kawasaki. I think they got on a little late. So could you do that, Dr. Lacroix?
Sure, sure. So the similarities are, again, fever that is persistent. They both have rash. They both have the involvement of the lips. They both have the swelling of the hands and the feet. They both have the conjunctival injection. For the most part, there are incomplete, just like we have incomplete Kawasaki. But the reason that we have the case definition is that you need to meet a number of these criteria in order to be reported. There is more gastrointestinal and diarrhea, vomiting, abdominal pain with this than we typically see with Kawasaki. And there is certainly more hypotension and decreased heart ability to squeeze. The myocardial function is diminished with this more than we see typically with Kawasaki, and there are more electrolyte and platelet changes than we typically see with Kawasaki. So we have both laboratory, clinical, and echocardiographic ability to pull these together to help us determine if this meets the case definition for the true MISC versus Kawasaki.
Okay. Somebody said that, if people are doing good hand hygiene and masking and 6 feet social distancing and staying home and not feeling well, is there anything else in general that you would say for a family that would be concerned?
I think a family that's doing all those things are doing exactly what they need to do from the well-established now public health measures to help us prevent the spread. They're being very responsible, particularly with being sure that they're masking when out in any public situation. We know people have to go to the grocery store and they have to go places, and that they're able to protect others and themselves. And then certainly hand hygiene is such a key factor because we know how often we all touch our face and our eyes, and just being able to have really good attention to that. And then being able to stay within our family units. I think families that are containing themselves to their family units are doing a great job protecting their children.
And how do you pronounce it exactly? Several people ask that.
Oh, well, I say MISC, multi-system inflammatory syndrome in children. Some people have said that this is all directly, the C should really be COVID, but the case definition and the CDC definition is that. And so I say MISC, just to make it clearer that I'm not speaking about miscellaneous.
Can it occur in kids who are asymptomatic?
That are asymptomatic from COVID. It has been described in kids who had minimal to no symptoms with COVID, and subsequently this is the inflammatory response that comes as the immune system has responded to that viral infection.
Okay, what advice do you have for limiting the spread in schools? What does this perfect setup look like for you? In your opinion, with what do you know about the virus, should parents be concerned about sending their children to school?
So I think the schools are doing a tremendous job looking at, as you all well know, every school's physical environment is very different. Every community's resources and ability to adapt is very different. And so I think that the schools have really done a tremendous job of looking at how they can modify how things are done and how they can rearrange what has been the previous school standard and adapt that to help keep children safe and following the components set out by both CDC and the American Academy of Pediatrics in terms of allowing alternative classroom setups to provide some distancing, being able to provide masks for teachers and children where appropriate, being able to provide good access and frequent hand hygiene, being able to have children do things in a different way so that they are able to continue to participate in the activities, but as opposed to all of the fourth grade classes having recess together, they may need to alter some of that. And again, it really almost has to be individualized to each particular school because their buildings and their facilities and their ways to implement are all going to be different.
How do we know, what do we know so far about children as vectors for SARS-CoV-2 and what questions remain?
Yeah, so fortunately, the evidence is mounting and continuing to be very encouraging that when you look at transmission by children, it's a very, very small percentage. Some studies as low as 8 to 10% are the children responsible, meaning that the adults about 90% of the time are primarily able to transmit. And that's based on a couple things. We know that the amount of viral replication with children is lower than that is with adults. So children are not the super spreaders that originally there was some thought that they might be the perpetuators of spread of disease. We know that the children are faring very well when they do get the infection. For the most part, their symptoms are milder and they require less, certainly hospital-based treatment. We know that the ability to transmit child to child is much smaller. There have been some reports that the CDC has shared, as well as some other literature reports where there were infected children in a multi-child environment and no transmission occurred within that multi-child environment, which is somewhat reassuring. So I think that us being sure that as adults we're protecting the children is one of the big components that we need to take forward.
Yeah. Good, thank you. It says that the person who was looking for information on the CDC website about national numbers, but they haven't really been able to see anything. Do you have any information about, is there that information available out there or not? Do you know?
I don't know. My understanding is that as we complete, it's a multi-page case report form. And as we complete those forms and send those in to South Carolina DHEC, and then subsequently those are sent on to the Centers for Disease Control, they then do an additional analysis to make sure that these truly meet the definition to be classified that way. So I would assume that the reason they have not released the national numbers are around them validating the information being sent in to be sure that these truly qualify to be classified as COVID versus being a Kawasaki diagnosis.
Dr. Lacroix, will you give your name and title again? I think we were missing some people at the beginning. I want to make sure they have that.
Sure. I'm Dr. Robin Lacroix. I'm medical director of the Children's Hospital, Prisma Health Upstate, and I'm also a pediatric infectious disease specialist.
And Dr. Lacroix, I think that's all the questions we have for the day, but could you just do a little wrap about this, what families can do in just a couple of sentences so that people, if they joined late, they'll have that?
Sure. So the multi-system inflammatory syndrome in children is an inflammatory condition that is either occurring at the time or shortly after a child has had a COVID-19 infection, and will present to the families with a number of different symptoms that include fever that is persistent, red eyes, red lips, red tongue, swelling of the hands and feet, rash, gastrointestinal symptoms, severe fatigue, weakness, any of those signs or symptoms that occur either in a child that's been exposed to someone and perhaps not yet diagnosed with COVID-19 infection, or a child who has been diagnosed and subsequently is either improved and then worsens or not improving. Those families should seek medical attention for their children over the concern around this multi-system inflammation, and to get those children into care and support so that we can get the appropriate therapy started.
The other thing that got asked was people were asking about the numbers for the state for children with COVID, and for this, that all information should be obtained from South Carolina DHEC because they provide the numbers for the state. And I don't think I have any other questions. Dr. Lacroix, do you have anything else that you want to add?
No, I just think, families understanding the things that they need to be doing to both protect themselves as adults, which subsequently we know protects their children at home.
Okay, one last question. Somebody joined in. Somebody said, can we please ask her to clarify if parents should be concerned about kids returning to school, or any advice about that?
So, I think children going back to school is a very personal choice in that family. Every family has a little different situation and needs to understand what fits their family dynamics. I think the school districts around the state are doing a tremendous job taking the input from multiple pediatric infectious disease doctors around the state, their pediatric consultants, guidance from CDC and AAP to create an environment. The school-based learning environment is very important for a number of reasons for children, not only educationally, but socially, emotionally, and certainly a number of our children don't have access to be able to do virtual learning in terms of broadband access or otherwise, and therefore the educational needs can't be met without the in-person environment for them to receive that education. And so I think each of the school districts is doing a tremendous job. If they have the physical space and the capability to do it, I think that they're going to be able to offer a way for children to do that. And I think it comes back to each family has to make the choice based on their specific circumstance as to what is best for their family.
Yeah. One last question and we're done. If you have additional questions after this, please let me know. But this question is about limiting activities. How does MISC limit activities for children, play, swim? I mean, should they be quarantined? Any of that kind of information?
Right. So many of these children don't have active RNA replicating in their nose. Many of them have antibodies and therefore would not pose any potential infectious risk. The children that are actively in their rapid shedding period would continue to be quarantined and isolated. And in terms of the long-term consequences, again, they are followed from a cardiology standpoint for quite a period of time. If they have pulmonary involvement and they've had pneumonia, they will be followed for a period of time with that as well. And so those specific release to activity is really child dependent. And in terms of the isolation, it really depends on whether they are farther in their course and they are diagnosed based on antibody detection versus with any evidence for active viral replication.
Good. Thank you. Thank you everyone for attending. If you need anything additional, please let us know. And I did record this for anybody who needs the recording, but I have to do it through the WeTransfer because it'll be a big file. So thank y'all, and we appreciate it. And we'll let you know the next time we have some. Thank you, Dr. Lacroix. We appreciate you so much for taking the time out today.